Hello, I'm Steve Cohen, and this is Congressional Report. Our report today is on infant mortality, a problem that plagues our state and, more importantly, our city. We are one of the most crisis spots in the world on infant mortality, and we plan to attack that in this congressional session and discuss it during this panel, and we have a great panel to discuss it. On my left is Dr. Danny Reddy, who is the head of the neonatal center at the Med, an expert on this subject. It's Sheldon Corona's professor, and he was on the forefront of the infant mortality problem in Shelby County, and we welcome you. Dr. Kenneth Robinson, who is the county health officer. Before that, he has been the commissioner of health in the state of Tennessee. Over pervasive of all of that, he is the pastor at St. Andrew's CME Church, and is a medical doctor as well as a pastor. Harvard undergraduate and Harvard medical with a Vanderbilt divinity degree. I mean, I don't know what, as a Vanderbilt graduate, you know, you did good.
I came home.
You came home and did good.
Thank you.
And Willie Henry, a member of my staff, been involved in the community for many years in many different areas, and works with us on this issue, and sees this as kind of a personal issue, because he, as so many people, have seen infant mortality and come in his family, and knows how it can affect people, as it's affected my family as well. Infant mortality is a crisis stage, and in our zip code 38108, we have one of the highest infant mortality rates in the country.
That's right.
Rivaling third world nations. We are around 30th, I believe, and there's in the world on infant mortality, and we should not be. We should be at the top. We're at about 30th is most prevalent. We've got a resolution we've introduced in this Congress, the 111th, supporting efforts to reduce infant mortality, HRS 260. And then we have a bill in the Congress, HR 3470, the newborn, which is an acronym, as all bills in Congress seem to have acronyms, the Nationally Enhancing the Well-Being of Babies Through Outreach and Research Now Act. That would create 10 pilot programs throughout the country to address infant mortality and gather statistics, and hopefully be a start towards some type of a program to lessen our rate of infant mortality, and that would be part of HR 3200, and we believe we're going to be able to get that in the bill. Great. Let me start with Dr. Danny Reddy. We were talking earlier, and Dr. Robinson, please jump in, and Willie. What is the reason for the high rate of infant mortality, in your opinion, in Shelby County and Memphis?
Congressman, thank you for giving me the opportunity to be here. The infant mortality is closely tied to the low birth weight rate and prematurity in Shelby County. And the factors for low birth weight and prematurity are really very many. Most of them reside in the community. By the time we have a premature baby born and admitted to my unit, we as a society have failed, and now the doctors are trying to deal with the preterm birth, and it's a lot more expensive than having to deal with preventing preterm birth up front. The factors are mostly that we all know, and they have been long simmering problems, and they are poverty, illiteracy, poor access to health care, and a family that is under stress. You know, studies have shown if you have an intact family, a married family living together, the infant mortality is lower in women who are married compared to single women giving birth. And studies also have shown if you have less than high school education, the infant mortality is high. Women who have poor access to health care, not only during pregnancy, but preconceptual well-being, that's very critical. You have issues of biological, psychological, behavioral issues that need to be addressed so that we really take care of this woman's well-being before she is ready to have children, so that pregnancy occurs under optimal conditions, and then you have good prenatal care, the likelihood of an optimal outcome is much higher. Here in Shelby County, we have a lot of single women with poor education, living under poor socioeconomic conditions, under very stressful family conditions, where a lot of these women do not have a husband with them.
And Dr. I think Dr. Danaretti really puts his finger on a lot of issues, and certainly there are issues that are associated with infant mortality. And when he talks about poverty, clearly there is a huge association with poverty. You're right. In Memphis, Shelby County, over half of the babies that suffer infant death, over half of those moms who have those babies are living in households, Congressman, where the family income is less than $10,000 a year. You're absolutely right that if a mom has not finished high school, she has a 70% greater chance of losing her infant than a woman who has finished high school. And so I think what we primarily want to suggest is that at one level, there are social determinants of health in general, which are compounded when they come into the issue of looking at infant mortality. So undereducation, lack of education, poverty, underemployment, poor housing. And now there is another whole component, as has been mentioned, that we assume stress, and particularly stress associated with race in the United States, seems to bring another component to why, very interestingly, even when one matches for income and education, other socioeconomic standards, the rate of infant mortality in African American women is still higher. And so there are many, many variables. We're not sure. When you talk about the new legislation that you're supporting that speaks to both outreach and research, it's very, very critical. Memphis is the perfect storm of all that could possibly contribute to higher infant mortality rates. Number one, we are a predominantly African American city. And so that additional element, that additional component that we're not quite certain, but researchers all over the nation and the Centers for Disease Control are all trying to understand what the additional factor might be. That component is there. But what we do know is certainly we are suffering from the kinds of things, the poor health of women in general, even before they're pregnant. So that preconceptual maternal health, poor nutrition, poorly managed and controlled diabetes, hypertension, sexually transmitted diseases, just poor health. The issue of poor family planning and the fact that we don't space our pregnancies out, and if women have babies right after other babies, it increases the likelihood of having a low birth weight or a preterm baby. Women who either don't have real access to prenatal care or don't have functional access. They don't really get in to see a doctor, so that, for instance, a woman who starts prenatal care, Congressman, in her 7th month of gestation or later is twice as likely to have a baby who dies in the first year of age. And over half of the women who lose babies have had absolutely no prenatal care or some unknown amount of prenatal care. These are things that we are clear about: the poverty, the presence of poor access to prenatal care. Those are things that we can put our hands on. And then there's the other unknown variable that seems to be at work in African American communities, and the perfect storm leads Memphis to have the highest infant mortality rate of any other large urban city of the 60 largest urban communities in the nation. You're right, worse than Mexico, Sri Lanka, Botswana. It just ought not be. And when you look at the relative rates of infant mortality in African Americans, 3 times higher in Memphis, Shelby County to the rate of infant mortality among white women and their babies, 3 times higher. That then isn't only a difference, that's a disparity. There's something very, very wrong with that, and it ought not be.
Let me ask you this, and you did some, and whoever wants to jump in, you did some work when you were Commissioner of Health for the state on infant mortality, and the county has some programs now
Exactly.
that predated your coming into the position as health officer. But Memphis is unique, and yet there are areas in New Orleans, in Birmingham, in Atlanta, I'm sure areas and other cities that are similar demographically. Is Memphis, what do you think it is that is unique to Memphis? I mean, the poverty, all the lack of access to health care, I would think that would be generally similar. Is it worse maybe here?
And I would say, I mean, your observation is exactly right. If you look nationally, the rate of infant mortality is twice as high for African Americans as it is for white Americans nationally. That's true across the state of Tennessee, twice as high as well. I'm certain that statistic would be similar in those other large, poor, urban minority communities that you've mentioned. The perfect storm in Memphis is that, again, we are predominantly African American, and so that component of race and stress, the stress of living as African Americans, and honestly, this is not just a hypothesis now, it's really being very scientifically studied and peer-reviewed research now, because that does seem to be a component, the fact that we are there and that we have huge pockets of lower socioeconomic status communities in Memphis seems to then push us from the disparity of twice as much infant mortality into the realm of 3 times as much infant mortality when compared to babies born to white women in Memphis, Shelby County. Because as you know very well, we have this huge disparity of some wealth and pockets of wealth in the white community in Shelby County, and then huge pockets of poverty. And so the disparity is compounded by and exaggerated by also the socioeconomic disparities that are existing here in Memphis, Shelby County.
Yeah, I agree with Commissioner Robinson that the infant mortality in all the inner cities is very high. It's not just Memphis alone, but I think we are grappling in Memphis because we have much more number of babies dying here than other inner cities. I mean, District of Columbia has a very high infant mortality. It usually doesn't come up in the statistics because it's not one of the 50 states, as we call. And if you look at the root causes in all of these inner cities, it is race, and it is poverty, it is illiteracy, it is just the stress of day-to-day life that these women go through before, during, and after pregnancy.
And to celebrate, we have one of the best and perinatal, neonatal units in the nation, I would say in the world here at the Med, and to your tremendous credit, when we look at perinatal care, it's one of the reasons that infant mortality rates in the nation have come down, but they have plateaued. And when we start then looking at solutions to then further moving the curve down, we've got to move beyond the extraordinary perinatal, neonatal, tertiary level care that we get. We do very, very well in what Dr.
Right.
Donareddy does.
You know, the zip code 38108 in North Memphis, predominantly low-income African American. Infant mortality rate is 31 deaths per 1,000 live births.
Right.
That is like the top or bottom zip code in the country.
Right.
Is there something, though, that Memphis has failed to do, which makes, I'm sure, like I said, Birmingham, New Orleans, Atlanta, Chicago on the south side, Roxbury, whatever in Boston, they don't have the same situation. Have we neglected having health centers? Have we neglected tackling this problem earlier?
Oh, I don't think that there's anything we have neglected doing. I think we just have more of the same in concentrated areas in Memphis. There are pockets, I'm certain, if we were able to move in sub-zip code areas, public health officials who are able to look at statistics, they would find in other communities smaller units and smaller segments of zip code areas in other cities that would probably rival that number. Our problem is magnitude. We are a huge urban center, as you know. I think maybe 9th largest African American community in the nation. So it is both numbers and magnitude. And what we are doing, I think, to the credit of our elected officials and our policymakers, particularly Mayor Wharton, as he built upon the summit that Governor Bredesen, and he sponsored 3 years ago. We in the State Department of Health wanted to put the spotlight on Memphis, Shelby County because of this extraordinary distinction of having that high infant mortality rate. We wanted to put the spotlight there, and I would say that what Mayor Wharton has done in follow-up to that kind of huge interdisciplinary, broad-based approach and awareness to infant mortality really also provides the key, the solutions to going forward. It's an excellent neonatal, perinatal care, but it is also in improving the health of women who are fertile and who will be having babies. It's also about getting women into prenatal care early in their pregnancies. It's about addressing the much harder issues of those social determinants, and that's why it's highly gratifying for me as a public health physician to see elected officials concerned about this, because at the end of the day, it's not just about the woman and her womb, her pregnancy, and the delivery of her baby, and teaching her to keep her baby on his or her back so that the SIDS rates are decreased. At the end of the day, it is about getting women out of poverty, getting them through school, getting them into good health care, which takes us into the health reform debate, and really helping women and their partners make excellent decisions about lifestyle.
That holistic approach, I think, that's Antoinette Holman's program, is it not?
It is, absolutely. And as a matter of fact, I think the responses to the summit have been to create a wonderful model. It's a national model called Community Voice, and that model mobilizes communities that are at-risk, targeted communities with very high infant mortality rates to help peer leaders and mentors support women to do the right thing, to eat right, to get their nutrition together, get their weight down, to stop smoking, to not drink to excess, and certainly if they're not pregnant, to make certain they're in good health care in general, and then prenatal care when they're pregnant. That's the Community Voice model. And then the Centering Pregnancy model, which also followed the summit, has been to introduce women who are at low risk for having an adverse birth outcome, having an infant death, but to get women into prenatal care early. They support each other in group sessions. There's good education. There's the camaraderie of being in a group where other women are of similar gestational age. They're going to deliver all around the same time, and to bring prenatal care to them as opposed to requiring people to go out of their communities and to go see a doctor or a nurse practitioner somewhere else. And so there are models which I think have been implemented and are now sustainable with appropriate resources that will help us get to the root issues.
Right. I like to say that preventing prematurity and low birth weight up front is the way to go.
You sound like Brian Dobbins now.
And you know, if you look at it, if you look at birth weight specific mortality in Memphis, it's as good as anywhere else in the world. You take a 2-pound baby, bring it to Memphis, you know, neonatal intensive care unit, or you pick any other intensive care unit in the world, we are as good as that. But the issue is we are challenged with a lot more premature and low birth weight babies. And we need to reduce that. Even if you look at a purely fiscal point of view, not to speak of all the social malady we have and the social costs we are incurring, it is enormously cheaper to
Absolutely.
take care of a full-term baby than having to deal at the back end with a preterm baby.
Absolutely.
You know, nationally, you know, Institute of Medicine reported a term baby costs about $3,000. A preterm baby costs about $55,000 on average. Some of my preterm babies cost close to $1 million.
10 to 20 times more expensive to care for a preterm low birth weight baby on the average. That's why it's a huge issue for public financing of
right. And even if you want to convince the fiscally conservative people, makes eminent sense to attack it in the community where we need to be addressing. And meanwhile, I had to make a plea, because I run this unit every day at the newborn center. while we are fixing the prematurity problem, I have to deal with every day with prematurity. And I admit about 1,400 babies to newborn center, and we need resources to continue to provide the top of the care that we want to. So it's a two-pronged approach. Go to the community, try to get all these root causes under control, which I wouldn't underestimate the challenge. But meanwhile, help us to take care of these babies because they're not going anywhere. Somebody has to take care of it.
Willie, do you want to jump in?
Well, excuse me, I just wanted to add, of course, everything that you've said has been true. One thing that I believe we make a mistake when we leave men out. There are fathers, brothers, uncles, grandfathers who are going to impact the way that the cultural framework that women operate in, our sisters, wives, mothers, that they operate in choosing how they're going to eat, how they're going to seek health care. One of the things that I'm doing in the Congressman's office here is I've been to your neonatal center, and I've talked with you before, and we're going to talk some more, but one of the things that we're doing here is we're trying to meet with people who have interest in infant mortality to try to find out ways of what are the best practices, where do we go from here. It looks like a huge problem is true, but along with that poverty comes you have to have economic development because to reduce some of the stress, not only do single women who need work have to have opportunities to work, but the fathers and uncles and husbands will need economic opportunity, and I'm talking about jobs. And so it's a large problem that we have to address, but we don't want to leave that population out, or they'll end up saying, well, that's somebody else's problem.
I totally agree with you. You know, I take care of a lot of premature babies at the newborn center. The striking thing is the men are missing. Men are missing. Mm-hmm. And babies born to single women have a higher risk of infant death than babies born to women who have a husband or a partner.
And I'm pushing back a little bit because I think probably it is as much related to the household income. And so again, you're right that obviously single women, single heads of household, one income families are going to have lower household income than even households where there are two adults
with low income.
With low income. And so clearly the rationale speaks to having the man present in the life of the woman and supporting both the preconceptual health of the woman and also the environment into which that baby is born. So you're absolutely right. And of course we could have the good discussion, as we ought to have as a preacher, about whether those couples ought to be married or not. But we certainly want to suggest that the household income is what is directly correlated there. And having men involved, you're right, is critical for many, many reasons. You want to have the men encouraging the women in their lives to just take care of themselves. As a minister, I'd say be good stewards of their own personal health. You want the men in their lives to take some responsibility for contraception and family planning. So that, again, we're not having baby after baby, because spacing out pregnancies for 18 months helps decrease the likelihood of a low birth weight or a premature or preterm baby. So you want those men involved. I would absolutely, you want men encouraging good lifestyles, that they're women who are pregnant, are not smoking, they're not drinking, they're in prenatal care. And so in the Centering Pregnancy Program, for instance, those groups definitely invite not only the pregnant woman, but their significant other, their partner, whether husband or not, to be with them. And that portends a good prognosis, a better prognosis for those kids.
Sometimes you may not have the man available. Does the mother of the mother, which is oftentimes...
She's always involved. Yeah, the grandmother. Actually, what is happening is I see a lot of children having children.
Right.
12, 13-year-old having children.
And they don't even talk about their pregnancy to their mothers, and so they don't get care, or they hide their pregnancy.
Exactly.
And then
It's a problem.
And then it is really the maternal grandmother who is taking care of these babies. And so we really need to address, starting from the middle school, if not earlier, reproductive health to these women. Because at 12, 13, 14-year-olds, they should not be having children of their own.
Be having sex. I signed on to a bill that Steny Hoyer is putting in to make the school the center of so much more in the community. And I went out to East High and Sheffield, and there's a third school, it might have been Fraser. They're getting health centers in the schools.
Right. Absolutely.
But everything ought to be centered really in the schools, and health care and sex education and different social programs, so that they are available. And we had Secretary Arnie Duncan, Secretary of Education, with us yesterday, and he, like I, would like to see longer hours of the school day and longer months of the school year, so that the children have the opportunity to have better education and more education, and not be as he put it, and I guess it's nothing unique, but I like the way he phrased it. He said, we still operate schools as if we were an agrarian society, so that the children get out at a certain hour so they go work in the fields.
Right.
Well, they don't work in the fields. So what do? Oftentimes, they're out. There's not after-school programs. The parent is not around, so they get in trouble. And a lady told me that people start having sex at 12 and 13 years of age.
You've spoken volumes there. When I was a resident in medical school, it was news when there was a 13-year-old at the Children's Hospital Medical Center in Boston who was pregnant. It's not news today. And to the great credit, I would say, of Dr. Cash, Dr. Hamer, particularly in Memphis City schools, they are aware of the need to have a primary health focus for their children. Healthy children make better students as well, and for the prevention of all the other sequelae of poor health. I would also say it's something that we really have to talk more about as public health professionals, as policymakers, as political leaders, because it is an uncomfortable subject for many parents, even when the statistics prove that our young men and women are being sexually active before they finish high school. Even when statistics prove that more and more adolescents are getting pregnant and impregnating young women, it is a very difficult discussion to have. Even when we know that an adolescent girl who gets pregnant has a 20% higher chance of having a low birth weight baby than an adult woman, it is a hard discussion to have, and it is particularly difficult when there is a very powerful vocal advocacy group of parents who really don't want this discussed. I agree that even if we still just have them for the 37 and a half hours a week that we have them now, we could maximize that opportunity to vaccinate or inoculate our young people against some of the behaviors that would lead them to get harmfully involved in premature sex and to get pregnant as adolescents.
What happens is, there's a constituency out there that doesn't want to deal with it. And that makes it difficult on the politician, school board member most germanely, I think, to get the schools to do what they need to be doing. And then as a minister, which is so important in our community, because so much has come through the church and still comes through the church, particularly in the African American community. Do you have that problem too? You've done so much with your church, with the CDC and so many outreach programs and different ministries. But is there a reticence there to get involved in those issues?
That's an excellent question, and I think one of the things that I've had some success, and the people at St. Andrew AME Church have brought to bear, is that we are clear that even in the faith community, the best message, the message that we can unequivocally deliver is a message of primary prevention. Take care of your body, make the right decisions, do it initially, do it up front. In the case of this topic, it would be a good steward of your body, don't get involved with sex, delay this decision making until you're married. And so even if the faith community became uncomfortable with the other messages, if you're already sexually involved, please access family planning. If you're already sexually involved, please consider using a condom so that you won't get sexually transmitted diseases and you won't expose yourself to HIV and perhaps get AIDS. Even if we're uncomfortable with that sort of dialogue, I think what the faith community does extraordinarily well is to work on the primary prevention end, and that's what I think we're suggesting could occur in the school systems. And we ought to be able to support primary prevention education in public schools, that we're not saying primarily if you're already engaged or this is how we want you to be engaged sexually, but oh my goodness, just delay, don't do, this is not in your best interest. You have an 80% chance of not finishing high school if you get pregnant. If you don't finish high school, you're going to be underemployed. Unemployed, you'll be working at minimum wage jobs, even though you've increased the minimum wage. But those are messages that we could unequivocally join hands with the public schools and say, at a minimum, let us drive this home for the hours that we do have your children with us in the school system.
Right. The other thing, Congressman, is, all right, this girl got pregnant at 13. Now we know this girl. She's high risk. She comes back to me at 14 or 15 with another baby.
Right.
17, another baby. As a society, we are doing something not right, because at least first time we didn't know this girl is high risk. We knew when she came back second time,
Absolutely.
you know, it's shame on us. We have not gone back, protected this girl
Absolutely.
from the same environment she went back. Something wrong. I have seen 17, 18-year-old girls coming back, gravid at 3, gravid at 2. And by the time they're 18, 19, they're already 3, 4 children.
Excellent
And this is very sad to me. As a society, what are we doing? You know, people say, fool me once.
George Bush tried
Yeah.
to say that once too.
Right. So, I think we need to provide a safety net for these children who already have been declared as high risk.
And you're right. When I was state health commissioner, actually, one of the directives that we shared with all of our employees in the public health departments across the state was to ensure that at a minimum, when we were running the pregnancy test, and a pregnancy test was positive, we knew that that adolescent was at risk and was sexually involved. So the cat's out of the bag. When we were involved in the prenatal care and we were ushering them through prenatal care into time of delivery, we knew that that young woman has already been identified now as being at high risk. And so at a minimum, what we then wanted to do, no longer primary prevention, was to institute very much no wrong door, all hands on deck, secondary prevention to keep that young lady from having a second pregnancy, and hopefully to intervene in her life in general, that she's going to help this baby that she now has had be healthy, and then to help her make the kinds of tough decisions that would change the course, so that she would not be back now gravid at 2 a year later.
The problem, infant mortality might be a microcosm of all the problems that Memphis and inner cities suffer throughout this country. And it's a mix of poverty and lack of jobs and lack of skills and education. And the etymology of that, I think, traces back for several centuries that has got us to that point. Where we are today, tell me this, what is the county programs? There are several county programs, and there's several programs in the county, and we tried to bring everybody together one day. What were there, about 8 or 9 different groups?
Right, at least.
8 or 9 different groups in the county working on infant mortality. Are you familiar with them, I presume? Do you believe they're working are they at cross purposes? Would they be better if some of these groups or all these groups were brought under one umbrella?
I think the more the better. They're all additive in their impact, and I think that the models that are being implemented, there are probably 12 or 13 different models. Some of them are targeting different at-risk groups, higher risk groups, young women that have been identified in multiple mechanisms through multiple or entities. I think they all are great. They're all working well. And in this particular instance, we can throw everything at the problem, and as many women as possible that can be reached with various funding sources, various supporting organizations, entities, it's great. Our problem is that there are 15 to 17,000 births in Memphis, Shelby County every year, and what we now face is the challenge of taking programs and initiatives to scale. And that's where we are working with Mayor Wharton. We are very excited about your interest in this issue because if nothing else, we have to have sustainable resources to not address 400 or 500 or 800 or 900 women per year, but we really need to ensure that of all of the thousands of pregnancies in Memphis, Shelby County, everybody is getting the best that we have and that we are targeting the women that we know are at risk. Women, for instance, that have lost a baby before, we know they're at risk. All hands on deck. All sorts of resources should be thrown at them. Women that have had low birth weight and preterm babies before, everything ought to be heading in their direction. But that other whole huge group of women who are not accessing prenatal care, the county, you're right, has moved towards now proposing that centering pregnancy, for instance, be taken to scale. In addition to providing it in some of the health loop clinics and at the Medplex, we're trying to find a way of getting not 400 women, but 4,000 women into centering pregnancy groups within the next few years, hoping that somehow we are catching women who have been previously missed or who may not look like they are at high risk, but who might be intercepted at a point that we can get them into good prenatal care. We need to do all of the programs and do all of them more for more women.
Is there a program that you're involved with or that you'd like to talk about?
Well, I agree with you that we need more people and more resources working towards this goal. But I sometimes wonder whether we could use some coordination to optimize the effect. We at the University of Tennessee, we have been working with our colleagues in maternal fetal medicine, not only look at this issue from the community point of view that we are all doing, but also look at some of the research that we could do within our own community. As I pointed out before, there are biological issues, there are behavioral issues, there are psychological issues, there are sociological issues. And I think, I said this before, you go to any big city, you got Heart Institute, Cancer Institute, but have you gone to any city, Congressman, where there is a maternal child institute devoting to problems of prematurity and infant mortality? And we just said we are number 29th in the world. So I like to see, with your help and other leadership in the state and the city, have an institute dedicated to women and children, addressing the issue comprehensively of infant mortality and optimizing pregnancy outcome. And where is the biological laboratory other than Memphis to study this?
And we would support that. I think that, again, the wisdom of the acronym that you mentioned and the fact that there ought to be both outreach and research is that there needs to be additional research. The Fetal Infant Mortality Review Program, FEMR, that Governor Bredesen with Mayor Wharton have brought to Memphis, Shelby County, is an opportunity to do additional research. In this case, sadly, it's retrospective research at trying to uncover some of the unknown elements that might have been contributing to the loss of an infant where there has been already an adverse impact. But we need more research, and I've suggested that nationally public health officials are looking at this issue because nationally the infant mortality rates are not dropping one whit. This is one of the major public health agenda items in Healthy People 2000, Healthy People 2010, and the needle is not moving. It's not moving nationally. It's not moving for racial and ethnic minorities. So the need for research is great. We have a tremendous research center. We'd be very supportive of that. We think it requires both and. Outreach to do the things we know impact infant mortality and can reduce the rates, and research to uncover some of the elements that we're not quite sure.
There's a man and I can't think, the physician at the CDC that's working on this.
Al Brown?
Yeah, and I met with him in Washington. I called him. I saw his name in Newsweek
Right.
or Time,
Right.
and I just called him up on the
Right.
plane. I got
He
him.
was a neonatologist in his previous life. Used to be at Emory and then Oklahoma City.
You know him, and he was friends with Coronas, I think, with Dr.
Right.
Coronas.
Right. He has been very active at CDC.
But he's put his money, or CDC's issues, into Mississippi.
Right.
Some rural and some in
Yes.
Jackson.
Yes.
And I've
he
been
has a
trying to pull him
right.
into Memphis.
I think we need in Memphis help. And I say this to all our citizens and community leaders. We got one of the highest infant mortality and prematurity rates. We need to be looking at comprehensively every facet of this problem. And maybe we learn something from here that the rest of the country can benefit. But we need resources to study this, to intervene measured way and measure outcomes. And so we need a comprehensive program.
That's why we introduced our bill, and we've got it pretty
Right.
much moved along to where we feel confident
Right.
that Frank Pallone, who's a
Right.
good friend, will and working
Right.
with, will get that in the bill.
Fund a maternal, fetal, and the neonatal
That's a great
institute.
idea, and we want to do that.
Right.
We've got 10 centers set up in the bill,
Right.
and the idea was that we couldn't just say do it for Memphis. It would be considered an
I
earmark.
think in any
so
way-
instead we
any-
said pick the top 10 places or
In
10 of the top
any
places.
yardstick, Memphis comes to the top for help in this one.
Right. And
know.
I
You're a
mentioned,
safe bet.
yeah, we'll be in the 10.
Right.
Then I mentioned it to Michelle Obama.
Yeah.
And when I was in the White House, and I urged her to get involved, and the March of Dimes wants
Right.
her to be involved in different issues, and as a spokesperson, and we hope
And you
to-
do know that the March of Dimes is the primary supporter of the community voice model, which is
Yes.
one of the reasons that Mayor Wharton has brought that model to the city, just to interject.
We've met with them at the district office.
Excellent.
And we're going to participate with the March of Dimes and all their different activities. And a lot of people don't know the March of Dimes, what it deals with now, because everybody still thinks that it's polio and FDR and Warm Springs.
Now they moved on to premature, right? Right.
But that's an issue we can work on. But Memphis would be a perfect center. And so that's a goal we've got. If a woman's out there and she's pregnant right now and she's watching the show and she thinks, I'd really like to do the right thing by my child, is there a place she ought to call? Is there a phone number that's one of these groups has that can call up and get some confidential information?
Oh, I think that certainly a top-level message is that if, number one, she has any access to health care at all, she should functionally get to that health access. And we're fortunate in Memphis, Shelby County, as you know, that our rate of uninsurance is relatively low. Actually, one of the very few things in Tennessee we're proud of, and that's partly because of TennCare. It's also because we have access to the community health centers, Memphis Health Center, Christ Community Health Services, and you know them very well. So we would suggest that she either get to her own provider that she may not know, or to one of the community health centers, or to call us at the health department. The other thing that we would just say to her is that in the meantime, eat well, please stop smoking, do not be drinking while you're pregnant. Please ensure that you're doing the things that keep yourself healthy, because a healthy house, so to speak, for a baby that's being formed will help that baby be healthy. And so we would encourage her to contact the church health center, for instance, if she does not have access to any of the other healthcare providers. And the Church Health Center, as you know, does an extraordinary job of taking care of the uninsured and persons who are not yet into TennCare. And so we would suggest that any of those resources which are readily available to her in Memphis, Shelby County would be ideal places for her to reach out.
Do you recall, Willie, I think one of the groups had a phone number to call, and I can't recall it, but they have a billboard campaign, and I thought that there should be something for if a young child is 12 or 13 and she doesn't know where to call, what to do, and doesn't want it. Sometimes, as I understand, they hide their pregnancy and nobody knows about it till they 8 months pregnant, 7 months pregnant.
Well, certainly a young child can always call the health department, and we are responsible. Memphis Shelby County Health Department. We are absolutely responsible for providing care in all sorts of circumstances and situations, and the federal government allows public health to do that without respect to many of the other kinds of barriers that would present for persons accessing health care. So clearly that's one resource.
Having discussed this issue, which is so serious, health care in general, H.R. 3200, or some reasonable facsimile of such, assuming it is not folded, spindled, and mutilated by the time we get back to Washington. I've asked Dr. Danny Reddy, and before we get his answer, I want your answer. What do you think we ought to do with health care? Are you a single-payer advocate? Are you a public option advocate? Are you a scratch the bill and start over advocate?
Let me start with my mantra for the last quarter century or more. It's a shame to be in the United States of America and have 47 million people without health insurance. And so I'm a pretty flexible fellow who would be willing to address multiple approaches to compromise as long as we're providing access for 47 million Americans to health care. It is a terrible indictment on the United States that we have that huge cohort of Americans who are not insured. It is directly proportionally related to their very poor health outcomes. And in the case of the topic today, it contributes to many of the reasons that women do not access health care, don't take care of themselves, will not access prenatal care at the appropriate time. So any approach, and I think President Obama has done a very wise thing in this instance, in that he has tried to give Congress the first stab at creating consensus and developing an approach that will get us to that end. At the end of the day, if Congress cannot, through its Brownian motion and sausage making, get there, I think the president will need to help us a little bit in the sense of his objectives of not increasing the federal deficit and ensuring that long-term health care costs decrease, but ensuring and providing access to insurance for all Americans, whether it is a single payer, whether there's a government option, whether there is some sort of co-op. I think we can be fairly flexible. I'm not an idealist. I'm not an ideologue about that. We just need to get to the end product for the end users, and so that people are not delaying their care because they have to pay out of pocket, don't have it out of pocket, or people are underinsured with the health insurance that they have, that in Memphis, Shelby County, they're becoming bankrupt and losing their homes and foreclosing on their houses because medical bankruptcies are leading them right into poverty. There's something very wrong with that picture, and we would hope that the spirit of compromise and just sort of the ethical universalism, doing the right thing for the greatest number of people, will lead Congress with some executive branch support to passing something. It really doesn't matter to me unless at the end of the day we get no plan whatsoever. That would be travesty.
Your position, there are two different issues, I think. There are many issues, but two overriding issues. One is the 47 million, and the other is keeping costs in control.
Right.
As 16% increase in health care, eating up a sixth of our budget and growing at a rate that's, and what we've talked about today, if we had health insurance for so many of these pregnant women who don't have health insurance,
right,
or don't have access to a physician, if what a major part of H.R. 32 is to see that we have more general practitioners, family docs in the community, encouraging them by paying them back their debt that they incurred in medical school, so they don't have to go into the $400,000 plus specialty programs.
Excellent.
And can go into family practice, go in the inner cities, go in the rural areas that are underserved, and provide the care. By doing that and spending the money on helping them pay off their medical school debts, we get the physicians that can treat and give care to these women, and saves us the money. Instead of having a $50,000 or $1 million pregnancy, we've got a much cheaper pregnancy, and you save money. Same thing with the health centers that are part of the bill, to get more health centers.
Correct.
Some people say send everybody to the Scott Morrison, the Church Health Center. Well, that's not the answer. Christ Community's done a great job, but there's not enough of them in Memphis Health Center. Those are places you save money. Now, you're a single payer. Tell me about single payer.
Well, in the industrial world, the only country that looks at healthcare as a business is us. All the other industrialized countries have realized a long time ago, healthcare and healthy citizens is an asset to a nation. Here we have businessmen controlling. We have everybody except the healthcare experts controlling the healthcare. The middleman takes a lot of healthcare dollars away from actually reaching the end users.
Now tell us who the middleman is, or the middle woman.
Middle woman, yeah. Well, just take Medicare Part D. How many vendors we have per each state?
Right.
That I rest the case. How many insurance companies we have? A doctor has to know each insurance company what the idiosyncratic way they want the claim filed, and how many insurance companies have credentialed a physician or a healthcare provider. So these are all middlemen. So if we believe that every American is entitled to basic health needs, I think that's a fairly basic premise we should be able to agree. We are willing to spend, what's the Pentagon budget this year? We said for common defense, we're going to spend $1 trillion to defending our country. Well, what more way to defend our country's interests than having a healthy population? Can't we agree that every child, every woman, every American citizen is entitled to basic health care?
That was Ted Kennedy's position, and some people argue. But he said it was a right, and it should be a right.
Well, it should be right, but people may argue it's not in the Constitution. But a lot of other things were not in the Constitution. We have agreed we're going to provide for our citizens.
And I think in healthy debate, you have to acknowledge that it isn't in the Constitution. But even for persons who only speak the language of fiscal stringency and budget and cost, it is an argument that can be made if people are really willing and interested in dialogue that would support initial investment, enrollment of the 47 million persons, which clearly would be initial investment, higher costs, but for the prevention of all of the downstream costs. And we've talked about infant mortality today and preterm low birth weight babies. That cost is immediate. If you've got a little baby, that higher cost, 10 to 20 times higher cost, gets immediately into the healthcare cost system. But chronic disease, which significantly impacts the cost of the provision of health care in the United States, can be prevented significantly by getting people into primary care, preventive care. So it is a difficult argument, in particular for people that are not interested in genuine dialogue. You've got to talk about initial cost and long-term benefit.
It is not a difficult argument. We have a single payer for all people. That's called Medicare.
Yeah.
If all people are entitled to a single payer, why aren't the other Americans? So I think, and Medicare, we have to agree, has been a greatest asset to our senior citizens. And
Medicaid to our low-income citizens passed at the same time in 1965 and decried as socialism by the opponents.
Well, Medicaid, unfortunately, is administered each state separately, and it has different standards. It hasn't done as well as Medicare. Some states have executed their budget. Other states are reluctant to even put up their 20 cents or 30 cents on the dollar to get 70 cents from Washington.
And yet you do not have the dialogue today. This is why we're talking about honest dialogue. You don't hear anybody in Congress, either house, talking about the elimination of Medicare. It's government-funded, government-operated health care. So that's a disingenuous discussion about not having government-operated, government-funded health care.
TRICARE. Or
That's
veterans
correct.
health care.
Exactly correct.
The health care you got.
And Medicaid, even though the cost of Medicaid and the burden, and that's an issue of poverty, and the eligibility for Medicaid because we have so many poor Americans, but people are not criticizing any longer as they did when the programs, as you indicated, were initiated. They're not criticizing the presence of Medicare and Medicaid. So that is not an argument that is valid. I, on the other hand, don't mind people having private health insurance. I think that's perfectly fine. We are in the United States. If it were possible for people to continue to access their private health insurance, they like their doctor, I think that's great. I understand that people are concerned about setting up a separate option that might provide some competition, but competition is a good thing. That's American capitalism. You have competition, and then the private industry matches, meets, and competes with public options. There has been an entire community of vendors and providers that have sprung up around Medicare Part D. There's nothing wrong with private business associated with public options and public approaches. But it really doesn't matter to me if we can find...
but we got to find an effective way. And
we've got to
like
find an
on the
effective way.
pharmaceuticals, and I support President Obama strongly. We've got a great relationship, but the administration cut too sweetheart of a deal with the pharmaceutical companies, in my opinion, and the House believes we did too. We may come up with something different, but they cut a deal with pharma at about $90 billion. We ought to be negotiating the price of drugs. The Secretary should be negotiating. We passed that as part of our 6406. We bragged about it, and then it comes down and somebody cut a deal with the pharma.
And every other country negotiates pretty hard.
Right. And that's then, where you get rid of the donut hole with this 3,200, but not completely till the year 2023. And it's hard for me to go to the Lewis Senior Care Center and tell people that because they're not going to be around in 2023, some of them. So there's a lot of things we need to do, and we need to make sure the pharmaceuticals, that the insurance companies, the wellness and prevention is so important. And if you have the docs and if you have the clinics and you get the wellness and prevention with no deductible, no copay, everybody gets it, seniors and children, you're going to prevent diseases.
Absolutely.
Prevent illnesses that cost more later on.
Absolutely.
Cost much more later on.
The workforce development is key, and I'm delighted that that's an element of the proposed legislation. As one who has been an academic medical center admissions and student affairs dean, we've got to get people into the workforce. We need to create more primary care physicians. And by the way, in Memphis, Shelby County, it's important for our University of Tennessee to continue to produce minorities who are going to practice medicine, because minorities return to lower socioeconomic communities to practice medicine at a rate of 4 times higher than their white counterparts. And so it is important in terms of policy, and it's important in terms of workforce production to continue to attract minorities to medical school and healthcare careers.
Right. And there are only so many Barbara Jeters and Jeff Warrens. We've got 2 minutes to go. I don't know where we should close. It's been a great discussion, and I think we're going to continue to work on infant mortality and work on health care in general. And I do think that all of it is a symptom of bigger problems which we've got with economic justice. I mean, social justice is there, but without economic justice, people can't have the education they need and the health care they need and access. Even transportation is part of it, getting to a health facility. And we have problems in all those different areas. It's a holistic approach is needed.
Correct. Very much.
I appreciate each of you being with us. And we're going to, your idea is great, and we're going to capitalize on it and try to get the First Lady to come to Memphis and to make that her goal. And Dr. Robinson, you've had such a phenomenal career and so much, and I appreciate your being here.
Thank you.
All the work you've done for the state and the county, and at AME. One time, you probably know this joke. One time I was at a funeral, and somebody came in and they said that there was a member of the church, and they said they'd never seen the deceased, and he said, well, he's CME. And he said, what do you mean CME? He said, he only comes on Christmas, Mother's Day, and Easter.
So I'm glad I've got members that come on other days as well.
I think it was Melvin Charles Smith told me that.
See you at St. Andrew soon.
Thank you. I look forward to being there. Willie, thank you for coming and for your work and staying involved.
There is another joke I need to tell you. Claude Pepper, you know Claude Pepper. All his life he worked on health care reform to our country. Finally, when he died, St. Pete was waiting for him. Mr. Pepper, come on in. God is waiting for you. So he gets, I hope, so he gets ushered into God, and finally, Mr. Pepper gets to see the God, I said, oh, God, I'm so happy to see you. I have a question, sir. I said, what is it, Mr. Pepper? Will my country, United States, will have health care reform, sir? God paused for a second and said, yes, Mr. Pepper, but not in my lifetime.
Hopefully he's wrong. Thank y'all for being with us. Thank you for the humor. I'm Steve Cohen. This has been Congressional Report. Appreciate your watching.